Um, all right, and just as a clarification, we're pausing recording until we actually get to the didactic, and our goal is only to record the didactic. Our case discussion isn't going to be recorded. None of our other discussion is going to be recorded. We're mainly planning on recording the didactic. Just in the interest of time, especially for all who are here, I'd like to welcome you to just type into the chat something you appreciate about one of your patients with ADHD, and then we'll go ahead and get started with verbal introductions. And I think this is a little bit inspiration for us. I'm famous folks with ADHD, so meaning that this is there's a lot of hope, and there's a lot that our ADHD kids have to offer to the world. And so I'll just start calling on people. When you call on, just please share your name and what clinic you're from, and just to keep things brief, we'll just keep it to that, and we'll share these other thoughts directly into the chat. Okay. So Liz, let's start with you. I think you're muted.
Okay. Hi, Liz Salzberg from Pediatrics. I would say probably their energy, because they have, I mean, it actually can be really fun to have all of that in the office sometimes.
This is true. Thanks so much, Liz. Dawn, name and practice, please.
Hi, I'm Dawn Rosenberg from Golden Gate Pediatrics.
Wonderful to have you. Tina?
I'm Tina Geller, also from Golden Gate Pediatrics.
Wonderful. Jocelyn?
Hi, I'm Jocelyn, she, her. I'm from UCSF Mount Zion Pediatrics.
Wonderful. Tracy?
Tracy McMahon, she, her, Golden Gate Pediatrics. I agree. I like their energy. Their energy is inspirational.
Absolutely. Lucy?
Lucy Hume, Golden Gate Pediatrics, she, her.
Wonderful. Meredith?
Meredith Laguna, UCSF Mount Zion Pediatrics, she, her.
Wonderful. Paul? I think you're muted.
Paul Silvestri from Golden Gate Pediatrics, Key.
Wonderful. Miriam?
Hey there, Miriam Rue, and she, her, hers, and my coworkers are having a hard time logging in because it looks like their login on the calendar says it's canceled. So that's why I just told them to check your email. They'll be here soon.
Yeah. Okay. So the reminder should have gone out with the right link. So hopefully we'll get that. Okay. Thanks, Miriam, for letting us know. And Lauren, let's go ahead and go to you.
Lauren Schumacher, she, her, and I'm at UCSF Child and Adolescent Psychiatry.
Wonderful. Petra?
Hi, Petra Steinbushel, UCSF Child and Adolescent Psychiatry.
Wonderful. Mary, if you're on. I guess we'll give her a minute. I'm Joanne Jung, general pediatrician at UCSF, and also part of the CAPP team. And so let's go ahead and move on to the announcements. So yeah, we tried to fix the whole Zoom thing, and sorry, as we're on our learning curve with multiple technological platforms, we've had a few technological fails along the way. Thank you for your patience along the way. But the latest calendar invites that we've been sending out that should be sending reminders like 1 day and 1 hour before, those should have the right links that work for us. So thanks, Miriam, for letting us know that the old calendar invite was having some problems, Miriam. And so we'll try and clarify that with folks as they're coming on. Looks like maybe we're getting a couple more people on here. Hi. we were just wrapping up introductions, Laura, and if you just want to just share your name, pronouns, organization real fast.
Okay, Laura Denenberg, she, her, hers, and UBCP Bankrupt Pediatrics.
Wonderful, thank you. So the latest calendar invites, the latest emails, those links should be working. So just please make sure to update your calendar accordingly. As I mentioned a little bit earlier, as people are coming on, we'll be recording the didactic portion of this session to post online later. And we're looking for case presenters for the summer. So for July, August, and beyond, if you've got a good case that you want to, if you want to share with us and get a little bit of help with, please let me know. The other way to do this, and I'll post this into the chat, here is the link to the Red CAPP survey where you can enter details about a case. That's another way of letting me know that you'd be free and interested in sharing a case sometime this summer, sometime soon. Any questions about that real fast before we move on? Okay, let's go ahead and move on then to the next slide. And Lauren, so Lauren is our subject matter expert today. She's a child and adolescent psychiatrist and one of our CAPP psychiatrists that you hear whenever you call into the line. She'll be speaking with us about ADHD today. Lauren?
Thank you so much. And I'm generally on Tuesdays, so if you call on Tuesdays, that's me. And I've got my co-presenter, my cat Zinc, here with me, who is very helpful for engaging kids with ADHD over Zoom. They would much rather talk with my cat than me. So I just wanted to start with that icebreaker of kind of thinking about what we appreciate about our patients with ADHD, because I think so often we tend to focus on what their challenges are, and that is going to be most of what we're focusing on today, since it's a really short amount of time to cover a lot of ground. But I just wanted to also have us keep that in mind too, that there's also a lot of strengths there. I think I saw themes around lots of creativity, a great sense of energy and enthusiasm, passion for what they're interested about. And those are all definitely strengths we see. So overall, the objectives today are to explain the process of diagnosing ADHD, discuss first-line treatments, and then describe common side effects and how to manage them. And this is going to be a fairly brief overview, so I apologize that we're not getting into all the details. And in terms of disclosures, no one involved in the planning or presentation of this activity has any relevant disclosures. So to start with, we're going to touch briefly on diagnosis. So in terms, when we're thinking about whether somebody has ADHD, we're looking to see that they have 6 or more of the symptoms in these two groups, the inattentive symptoms and then the hyperactive impulsive symptoms. We want to confirm that they've been present since before age 12 and that they've been present at least 6 months. So if it's something that has been very short term, it's kind of more of they were acutely having difficulties with attention, that might suggest that something else is going on, and that's less consistent with ADHD. And then we're always looking for that functional impairment piece. So is this getting in the way? They may have trouble with focusing, but if it's not really affecting their functioning, then that doesn't meet criteria for the disorder. And finally, that it's not from another disorder. So thinking about, are there sleep issues, nutritional issues, other things that might be affecting their focus. So this is a lot, kind of 18 symptoms is a lot to keep in mind. So I recommend using one of the rating scales. We most commonly use the Vanderbilt rating scale, but the Conners and SNAP all kind of are well validated and cover the same 18 symptoms. On the CAPP website, we have links to the Vanderbilt rating scales. Both there's an initial one that kind of goes over, in addition to ADHD, some common comorbidities like anxiety and depression, oppositional symptoms. And then there's follow-up ones that are shorter and focus just on those 18 ADHD symptoms. And often it's helpful to do The rating scales at the beginning, kind of both to help you assess, do they meet criteria for ADHD and to provide a baseline. And then kind of when you're making medication changes during treatment to see if you're noticing differences with different doses. It's also important to kind of keep in mind if there's comorbid conditions going on. About some studies suggest that about like 66% of people with ADHD have a comorbid psychiatric condition. So these things can be things like anxiety, traumas, learning disorders, oppositional symptoms, sleep problems are all very common. I mentioned the Vanderbilt can be helpful for screening for some of these other comorbid conditions, but it's just something always to keep in mind. And that's also a good opportunity to consider a call to CAPP if you've got questions about potential comorbid issues complicating the picture. And our case today, I think, is going to be a great example of complex comorbidity. So then, once you've talked with the family and patient and gotten feedback from the teacher, you think they meet criteria for ADHD, thinking about treatment, the things that are recommended by the American Academy of Pediatrics clinical practice guidelines for ADHD are to think about psychoeducation, so educating the family and patient about ADHD, behavioral therapies, and this is first line for 4 to 5-year-olds, and then first line along with medication for 6 to 18-year-olds, school accommodations and interventions, and then medications, which FDA-approved medications are first line for 6 to 18-year-olds, and then methylphenidate would be the second line option after behavioral therapy for 4 to 5-year-olds. And we're going to go into a little more detail on each of these. So some helpful resources for psychoeducation. One is the CAPP website, which is linked here. There's some great resources for patients and families about ADHD. A book I think is particularly helpful is Taking Charge of ADHD. It's a book kind of written for parents, and it goes into a lot of information about ADHD. It also covers a lot of helpful behavioral strategies that parents can use. In terms of medications, ACAPP and the APA societies have a ADHD Parents Medication Guide, which is a great resource written for parents, but I think it's really helpful for providers to read as well, because it talks about ADHD and it covers a lot of the common questions parents might have, things about kind of, especially a lot of their fears, like does this change their personality? Is this going to make them addicted to substances? And it does so in very kind of parent-friendly language. So I think that's a great resource. Another resource for parents that can be helpful is Straight Talk About Psychiatric Medications for Kids by Timothy Willens. That covers ADHD meds, also other meds. And then Attitude Magazine, ADD, is a nice resource that has a lot of information for parents and families about ADHD. And then in terms of behavioral therapies, for kind of the most challenging cases, you might want to consider a referral to something like behavioral management training or parent management training or a positive parenting class, because often even positive parenting is less directly targeted at ADHD, but it covers a lot of the same behavioral strategies. But often those referrals can be hard to make sometimes. So some strategies that even kind of in the office to kind of talk about or refer them to some of the parent books like that, Taking Charge of ADHD, include encouraging attending time or quality time. So often ADHD kids are getting a lot of negative feedback. They're doing things that are irritating their teachers, irritating their friends, irritating their parents. And so they get in these negative feedback cycles where that's kind of all, you often hear like the parent and kid, like the only interaction is around like conflict about homework. So encouraging having some kind of quality set aside time that's child directed, where the parent and kid can spend time together, that alone can make a big difference sometimes. And then encouraging structure and routines, having the same routine every morning, having a visual schedule of that routine to help have reminders, using rewards for things, using simple instructions. So sometimes the parent is yelling from across the room 3 different things to do. And that with most kids, that doesn't work. And with our ADHD kiddos, that especially doesn't work. So being in the same room, making eye contact, maybe touching them on the shoulder and one instruction at a time, things like that are things that parents can kind of implement on their own and can make a big difference. And then in terms of school accommodations, for public schools, that would be something like a 504 plan or an IEP. With private schools, it would be kind of more just informal accommodations that they work out with the school. But that can be things like preferred seating arrangements in a place that's less distracting, potentially extra time on tests, the ability to have a quiet place or silencing noise canceling headphones during testing, things like that. Ability to take breaks or use like a wiggle seat or fidgets can all be helpful. There's Attitude has some good resources on kind of common accommodations that can be helpful for people with ADHD. And then in terms of medications, so the FDA-approved medications for ADHD include the stimulants, which are the methylphenidates and amphetamines, the alpha-2 agonists, which are guanfacine and clonidine, and then the alpha-2 agonists in combination with stimulants, and then atomoxetine, which brand name is Strattera. I'm going to touch on these briefly. You also got a handout as part of this, and the handout kind of goes through the details of most of the stimulant medications available, as well as these other medications, kind of common starting doses, common therapeutic doses. So refer to that for more detail. So in terms of stimulant medications, these are our first line treatment for ADHD for 6 and up. And that's because they've been found to be, they're well studied and have found to be the most effective medication for treatment of ADHD. However, there are some pretty common side effects. Decreased appetite is probably the one we hear about the most. There also can be issues with weight loss, sleep disturbance, things like stomach aches and headaches. Less commonly, sometimes there'll be behavioral rebound, increases in blood pressure or heart rate, sweating or tremors. And rare, very rare possible side effects include things like psychosis, hallucinations, compulsive skin picking. So some things that can be helpful with managing these common side effects is with the decreased appetite, that tends to hit lunch the most. So kind of encouraging them to eat a little bit more during breakfast and dinner when the medication is wearing off, and kind of have substantial meals then can be helpful. It can also sometimes be helpful to, if it's a particular concern, considering like short acting so that it's wearing off sooner and there's more time during the day when they're not having that appetite effect. If they're complaining of stomach aches, making sure they're eating something before taking the medication can help. And then if there's issues with sleep disturbance, finding out when they're taking the medication, encouraging them to take it earlier in the day, potentially switching to a shorter acting medication, and then could consider adding melatonin. That can often be helpful with sleep, or switching or adding an alpha-2 agonist. And then if there's issues with rebound, where kind of we expect as the medication is wearing off that the ADHD symptoms are going to return. But for some kids, they seem to kind of return even worse than they were before. And that's kind of what we think of with rebound. And what can be helpful with that is sometimes shifting to a longer acting agent if they're on a shorter one, or sometimes adding an afternoon boost can kind of help make the wear off of the medication more gradual and smooth that out. Then in terms of what to think about when choosing a stimulant, there's a lot of different options, which can be helpful, but also confusing at times, I think. So the first thing I think about is, can they swallow pills, and what mode of administration are we talking about? So if they can swallow pills, then you kind of have all the options. If they can't, then you want to think about ones that can be chewable, liquid, or there's some that like Ritalin LA or Focalin, they're capsules, but you can open them and sprinkle them. Then the next thing I tend to think about is the duration of action. So thinking about, is this a younger kid that has a shorter school day and not many demands after school? Is this a high schooler who has a full school day, activities after school, and then is doing homework? I generally, for the most part, I do start with a long-acting one, even with the younger kids, just to kind of give them coverage throughout the day, and then they don't have to worry about dosing multiple times a day. But that can also, often families have preferences too about longer or shorter acting. And here on the right, we just have, this is a graph of some of the different methylphenidate medications, and you can see that some of them do last a little bit longer than others, and also have somewhat different profiles in terms of their concentrations in blood. And sometimes I get questions about pharmacogenetic testing. At this point, there's really not much information, data in terms of using pharmacogenetic tests, and there's not much that tells us about different, they don't really comment on different ADHD medications, so it's not really useful at this point, maybe in the future. Okay. And then in terms of monitoring, I'm not going to go into everything on this slide because of time, but it's there for your reference. But especially before starting stimulant medications, you want to screen for a personal or family history of heart problems and also other potential contraindications like a substance use disorder, eating disorder, seizures, psychosis. You want to get baseline vitals as well as an ADHD symptom rating scale. And they've found that more frequent visits are actually associated with more effective treatment. So it's helpful kind of when you're first starting the medication to kind of check in every other week, kind of as you're first getting started, and then monthly for the first few months as they're kind of getting settled in on a dose. And then kind of continuing to check on weight and vitals during those visits. In terms of the alpha-2 agonists, guanfacine and clonidine, some of the most common side effects are somnolence, fatigue, and sedation, so they can make you tired. We generally kind of try to manage that by having people take them at nighttime, at least to start with, and that can help minimize it. And sometimes we'll actually, the making tired can be an advantage if it's a kid with ADHD who also has sleep problems. They're kind of less commonly, there may be issues with headache, nausea, low blood pressure, dizziness, and very rare side effect of hallucinations with guanfacine. In addition to dosing at bedtime, clinically, there's some sense that guanfacine might be less sedating than clonidine. So that can be a good choice if that's a concern. If there's issues with dizziness, making sure they're staying well hydrated, encouraging them to sit up slowly when lying down, and monitoring blood pressure. And then if it's, sometimes this is something that kind of happens briefly as they're adjusting to the new dose. But if it's something that persists, then considering lowering the dose or switching medication, and encouraging them to eat before taking it if there's issues with nausea. And then with atomoxetine, some common side effects are weight loss, nausea, GI symptoms, decreased appetite, headache, tiredness. And rare ones would be priapism, disturbances in sexual function, increased SI, psychosis, liver toxicity. And I think while there are issues with potentially weight loss and decreased appetite with Strattera, it does seem to be less so compared to stimulants. And this is one where if you start by dosing twice a day and waiting at least a week before going up to the full dose and then consolidating into once a day dosing, that can help, especially with some of the nausea and GI side effects. So then just kind of thinking about things overall with kind of all these kiddos always want to be thinking about healthy lifestyle, activities, nutrition, sleep. If they're under 6, first-line therapy, the first-line treatment would be behavioral therapy and school accommodations. Over 6, we're thinking about stimulant medication, behavior therapy, and school accommodations. If you are starting on a stimulant and there's no or partial response, you want to first optimize that dose. If either on a high dose of that, there's not much response or there's issues with side effects, then try a stimulant in the other class. So either starting with methylphenidate, then switch to an amphetamine, optimize that dose. If there's issues again with either lack of benefit or side effects, you could then kind of, the third medication would be either switching to atomoxetine or switching to an alpha agonist, guanfacine or clonidine. And those are, and then kind of on the side, if there's issues with sleep, always recommend, checking in around sleep hygiene and then considering melatonin or an alpha agonist. And I have bupropion here as well. It's not FDA approved for treatment of ADHD, so it's lower down in the algorithm, but there's some evidence that it could be helpful. And then kind of just, I think the AAP guidelines really well summarize kind of the different things to be thinking about with ADHD. So it's a very common disorder. So with kind of 4 to 18-year-olds, be having that in the back of your mind and keeping an eye out for concerning symptoms of it if they're having trouble in school, troubles with attention hyperactivity. If you have concerns, then use one of the rating scales to make sure DSM criteria is met. You want to make sure to be getting it from multiple reporters, so getting input from the teacher, as well as parents and the patient themselves. Keeping an eye out for occurring different mental health and physical conditions that might be affecting their focus, their behavior, and kind of using a chronic health model to treat ADHD and to check in around ADHD symptoms. And then in terms of treatment for preschool 4 to 5-year-olds, behavioral therapy is first line, methylphenidate is second line, and then that 6 and above, kind of first line would be a FDA-approved ADHD medication with behavioral and educational interventions. You want to keep increasing the dose to maximize benefit and can use those rating scales to kind of track to see if you're seeing additional improvement with the higher doses. And trying to find that balance of optimizing benefit while minimizing side effects. And then with primary care providers who are experienced with diagnosing and dealing with comorbid conditions can also initiate treatment of that, but that's also a good place to think about calling CAPP or potentially making referrals if needed. All right, and those are references for more reading.
Let's just pause here. Thank you so much, Lauren. And we have like about a minute or two before we have to jump into the case. So I want to open up if somebody has like a burning question that they want to ask of Lauren about ADHD.
I do, but it might be, can you hear me?
Yes.
Yes. I mean, just the whole idea of like the Concerta versus Focalin versus Adderall, like I usually start with the Concerta, but like, is there a flavor that you like for a particular patient?
Yeah, that's a really good question. And I think it is, in some ways big picture, they're all more similar than different. So there's not great guidance on what to start first. If there's a family member who's done well on a certain stimulant medication, I'll tend to start with that. There's not data to support that, but the thinking that if they've done well with it, maybe someone else will too. And there's also then just like the psychological good association of, oh, I found this helpful, so maybe they will too. I tend to start with a methylphenidate first. I very commonly start with Concerta. There's some meta-analyses that suggest kind of no difference in side effects or efficacy between methylphenidates and amphetamines. There was another meta-analysis done that suggested that methylphenidate had a little less side effects, but amphetamine had a little bit more benefit. So with a lack of further guidance, I tend to start with a methylphenidate first and then switch to an amphetamine second.
Okay.
I do think, with kids with a lot of anxiety as well, kind of longer acting ones that kind of have a gradual onset and offset can be better than sometimes the shorter acting ones. So things like kind of slow onset offset ones like Concerta or Vyvanse sometimes, like for kids with anxiety.
Okay.
Thank you.
That's a great question.
All right. Okay, we'll take one more real fast,
Then
Tracy.
Dawn, go to Dawn.
Well, this goes
Okay,
straight with Lauren.
fine.
So Lauren, between methylphenidate versus dexmethylphenidate, do we have to consider that, or are we just putting them all in the methylphenidate group and we don't really have to dig into isomers?
Yeah, I think they're, you know, they are a little different, but we don't have studies kind of directly comparing them. Sometimes I'll think about that if I've had a kid who's done well, like benefited from a methylphenidate, but having some issues with irritability or side effects, I might sometimes think about switching to Focalin, the dexmethylphenidate. So maybe sometimes there's less side effects, but I think we don't have data for it, so it ends up being kind of just that clinical judgment piece. But I do have kids like, oh, it's like Concerta is helping, but they're having some irritability or anxiety. Maybe we'll sometimes switch to Focalin rather than directly switching to an amphetamine.
Thanks so much, Lauren. That's it for the questions. Let's go ahead and move on to the case.
Could I have one more
At this
question?
point.
I just would like quick advice for if I have a high schooler or a college student coming now, they want ADHD medications, and I always get a little bit suspicious. Usually I only would do it if I have a neuropsych eval saying really, yes, this is ADHD. And then what to start with. Is it true that Vyvanse is less kind of attractive on the black market because it doesn't give you the kick like the other ones if you sell it?
Yeah, so I'd say any of the long-acting ones are good that I would consider in those cases. Just they don't have the kick that the short-acting potentially do. Vyvanse isn't active until it's gone through first-pass metabolism. So the particular advantage of Vyvanse is if you were to crush it and like snort it, or it wouldn't be active because it has to go through first-pass metabolism to be. So that is a particularly, probably of all of them, the hardest to abuse.
Wonderful, thank you so much. We really do need to move on to the case, so that was fantastic, Lauren. Appreciate it. So I want to turn over to Tracy, and this is just a quick reminder of our case discussion format, but Tracy has a wonderful case for us today, a complex one. So go ahead and take it away.
Okay. Yeah, so this gets to the topic of, I feel like, as you said, ADD, there's a lot of comorbidities, and this is one that particularly jumped out. So this is a 12-year-old girl. I met her back in 2016 when she had first moved here from New York with her mom and her new stepdad and her new baby sister. She didn't have a relationship with her biologic dad, and they moved out here for her stepdad to start a medical practice in San Francisco. She adjusted to the move great. She's super smart, loves school, loves science, had many best friends. And I pretty much saw her for checkups for the next 3-4 years. And every time she was really smart, really happy, very energetic, aspired to be president of the United States one day, just really adjusted to the fact that there was, a stepdad, that there was a new baby sister, then came along another baby brother, really happy girl. And then in early 2020, she had a protracted pneumonia, for whatever that's worth, between February and March of 2020.